in the few minutes we have left, we are going to talk about subtroch fractures. And the first thing that's interesting about them is that there is no classification in the new 2018 update of the AOT classification. Meinberg and company did not include any special mention of the subtroch fractures. In fact, it's just considered a shaft fracture, and with a small qualification of the being a proximal shaft fracture. Before that, people talked about the 5 centimeters from the lesser troch as being the subtroch area, and decided that we'll see why they wanted to separate it into a separate category. So if you go to the classification, really all you have to do is just treat it as a shaft fractures. You have in shaft fractures, you have your A's, simple fracture patterns, B's, wedge fracture, and C's, segmental fractures. And then you just put a parenthesis A to indicate that it's a proximal third fracture. So really simple in terms of classification. But previous classifications did make a big deal of the fact that it's subtroch because of these deforming forces. And you have different deforming forces on the proximal and distal femurs. The proximal fragment gets abduction from the gluteus medius and minimus, flexion from the iliopsoas, and external rotation from the short external rotators. And then the distal fragment gets its adduction from the adductors and the shortening from the hamstrings. So a lot of the deforming forces that are not typical of a shaft fracture, which will have much more balance forces on the fracture fragment and much less displacement. So this classification, the Russell-Taylor classification, it's an old classification, really took notice of these deforming forces. And you can see actually it becomes increasingly easier to reduce the fracture as you get more higher in the classification, because you have the type 1As, which have all of the deforming forces, the type 1Bs, which have the lesser troch off, which you take off the iliopsoas deforming force on the proximal fragment. And then if you have a fracture that goes through the piriformis, then you take out the abduction and external rotation forces on the proximal fragment. So this is an old classification. It wasn't incorporated into the new AOT classification, but maybe that's something for the near future. Decision making, another algorithm by Dave Shearer in the OTI decision making book, but really it can be summarized to always nail these fractures. You always basically nail. I think one nice thing that Dave put in here is that these fractures nowadays are typically seen as a pathological fracture or a Fosamax fracture or bisphosphonate fracture. And these are so look out for that. When you see a subtroch fracture, look out for the sign of a bisphosphonate fracture, like lateral cortical thickening, transverse fracture type, medial spike, which I don't know if you can see here, and lack of a comminution. Another thing that's nice in this algorithm is it shows you what to do if you have the only reason not to do a nail is that if there's a contraindication to a nail, like a deformity and so forth. And then there's other options like a blade plate, condylar screw, and so forth to treat these if you don't have a nail. So it's always nail. If you have, then all right, final poll. A 68-year-old female presents with the following fracture. You decide to open, reduce this fracture. If you decide to open, reduce this fracture, what are you doing? You're increasing the chance of infection. You're increasing the chance of non-union. You're increasing bleeding from this fracture, or just making your life easier. What happens if you do an open reduction of this fracture? Because most female fractures we treat with a closed reduction. So final poll. All right, and it's a really tight race right now. 50% engagement, 60. All right, that's the last poll. 64, and all right, so I don't think there's going to be a clear winner because you're so tight. The race is so tight. All right, so no clear winner, but there's a slight lead to making your life easier. And let's see the correct answer. It is going to be, and that is the correct answer. Okay, so this is based on a JBJ study. It's a case series from two large centers looking at these fractures, and they compared to historic controls, opening all of them. They did not find any increase in infection or bleeding or what have you. What they did find, and because most of the bleeding you should know about with nails, although we call them minimally invasive, this this procedure has more bleeding than for a DHS, for example, or I mean a plate operation, because all the bleeding that we're creating with a nail, it's uncontrolled bleeding. We're just streaming into the canal, and we're just creating tons of bleeding without being able to control it. So there's actually more bleeding with nails compared to plates. So that just the opening, the small opening, doesn't really significantly increase the bleeding. But most important, there was no increase in non-union. And you can see this is a very modest opening. It's not like a huge stripping of the soft tissues, but but just doing the open reduction just simply makes your life easier. It's much easier to get a good reduction, not to fall into varus, and get a good outcome with this opening. So most of us, myself included, will just go to this maneuver right off the bat if you have if you have a significant displacement in a subtroch fracture. All right, so hopefully the objectives of this talk were met. I will now open for questions or concerns about this talk. Anybody left on the call? No. Everybody happy, satisfied? All right, good. Then there's no questions, and nobody wants another poll. Then that will be it.